Ladies and gentlemen, if you would take your seats, please. The next panel is about to start. Thank you. Good afternoon, and welcome to this panel on addressing the mental health burden in and after crises. My name is Anand Galapati, and I will be facilitating the conversation in this room for the next 90 minutes. And the panel, of course, is also being live streamed on YouTube. Over the past 3 decades, the provision of mental health and psychosocial support to people affected by humanitarian emergencies has gone from being an afterthought or a fringe concern to being increasingly recognized as one of the key pillars of the response to conflict, disaster, and public health emergencies. I'm very privileged today to be moderating a distinguished panel with extensive experience and expertise in this field, who will provide us all with an overview of the state of the field, sharing key insights and lessons from practice, as well as highlighting some of the priorities for the work ahead. Before I ask the panel to introduce themselves, I would like to invite Parliamentary State Secretary Niels Annan of the German Federal Ministry for Economic Cooperation and Development to say a few words about why BMZ is hosting this panel today. Mr. Annan.
Thank you. Thank you very much, Honorable Minister, Excellencies, ladies and gentlemen, welcome to Berlin. Picture the following scenario. The war has ended. The natural disaster has passed. The pandemic is finally under control. Houses are still destroyed, but the streets are no longer empty. People start returning to their homes. From the outside, it looks like it's starting to heal. But underneath, there is something that too often goes unseen. When people are forced to leave their homes, when loved ones are killed or going missing, the mental health impact and the need for support are immense. In an acute crisis, it is only natural that we address the visible physical injuries and basic needs first. Nobody is criticizing that. Yet the far-reaching psychological impact to crises is too often overlooked. The World Health Organization estimates that at least 1 in 5 persons who experience conflict develop mental health problems. And that is why psychosocial interventions need to come in a timely fashion, and that's also very important, be accessible for all who need them. And we need to look beyond the immediate emergency response and integrate mental health services into recovery and reconstruction. So, ladies and gentlemen, strong health systems, from our point of view, are key to ensuring access and service coverage at the community level. Countries with strong health systems are more resilient in times of crisis. And to answer your question, that precisely is the reason why Germany's development policy, a key priority for us, is to integrate into our health policies the promotion of strong health systems in our partner countries. And that's what we have been working for many, many years. Germany's development policy promotes mental health through bilateral cooperation, which is the traditional way we address our policy, but also through multilateral cooperation. I want to give you a few examples. I had the privilege to make a pledge to support MHPSS in working with UNHCR at the Global Refugee Forum, for example, which I think, given the current crises, remains very important. I want to mention another example. The global program which we are running right now, called Hospital Partnerships, some of you might are familiar with that, comprises projects around 14 countries for strengthening global mental health. In Vietnam, for instance, hospital partners are developing projects to address the needs of the most vulnerable groups. Mothers at risk, for example, and school children vulnerable to self-harming behaviors. In order to integrate mental health into preparedness, response, and recovery. You want to give another speech? Welcome. So in order to integrate mental health into preparedness, response, and recovery, we need global coordination and we need dialogue. And that's one of the reasons why we are very happy to be partnering here and to welcome all of you to the World Health Summit. Together with the Netherlands and the EU Commission, Germany initiated a multi-stakeholder pledge in December 2023. The aim is to systematically integrate mental health and psychosocial support into humanitarian development and peace-building projects. That is much easier said than done. It requires real political effort and leadership, and we are very grateful that we have many partners in development cooperation, but beyond, also in the private sector, that are highlighting the importance of that issue. So I want to highlight also another aspect, if you allow me, Chair, which is the Global Disability Summit, which Germany will host together with Jordan and the International Disability Alliance on the 2nd and 3rd of April in the next year here in Berlin. And of course, mental and psychosocial support will be addressed. So I invite every one of you to participate, and especially invite all countries and organizations to contribute with meaningful political and financial commitments towards the faster implementation of the UN Convention of the Rights of Persons with Disabilities. So, as a parliamentary state secretary in the German Federal Ministry for Economic Cooperation and Development, I am now happy to welcome you to the high-level panel on addressing the mental health burden in and after crisis here at the World Health Summit. And I would like to thank our moderator, of course, and all the panelists for being here. And I'm very happy, I mentioned that before, that we have so much expertise here in the room to talk about, I repeat that, integrating that issue in our policy is easier said than done. So the different context matters, the different governance capabilities matters, but at the end of the day, everyone who takes ownership of that issue can make a difference. We believe health is a human right. And let's not forget that it includes physical health, mental health, and social well-being. And let us all continue the dialogue, collaborate and learn from each other. That way, addressing the mental health burden can be part of both the humanitarian response and the long-term development cooperation. So I thank you very much, and I'm looking very much forward to listen to that great panel.
Thank you, Mr. Anand, for those words and for setting the scene for the panel. If I could invite the panelists to take the stage. The panelists for this session represent very rich and complementary perspectives from government, global agencies, and civil society. And to give you even kind of a little glimpse of the highlights of their achievements and their CVs would take far too long to summarize. So I thought I'd instead invite each of them in turn to introduce themselves to you in just 2 short minutes with a brief insight into their relationship to this work. So welcome to you, panelists, and thanks for joining us this afternoon. I'm going to ask each of you in turn to introduce yourselves in terms of your current role, but also to share with us how you first came to be involved with mental health and psychosocial support work, and what does this work mean to you personally. Perhaps I'll start with you, Mr. Chimbonda, and then move down the line. Thank you.
Thank you so much. My name is Kumbise Kandodo Chiponda. I'm the Minister of Health for the Republic of Malawi. Thank you so much for the invitation. Coming to your question, issues of mental health, to me, it's not just as a minister responsible for health in Malawi, but they're also personal as well. I have my nephew and his wife. He had a mental breakdown. And this is a young lady, around 35, good job, she's a graduate, 2 children, 2 sons, and you just wake up, there's something wrong with her. And you can't tell, you cannot ask her what is wrong. You ask your son, what happened? Did something happen during the night? He said, no, we went to bed, okay. But in the morning, there she was, meant to break down. So we had to seek medical help. So basically, it just showed to us that mental health issues, they're real. Mental health issues is not about whether you've gone to school or not. It's not about whether you have money or not. It's a condition, it's a disease which needs attention. And all of us, we have to pay attention to it. So that was the first time. But as well, as a minister, the issues are real for different reasons, economic issues, climate change impact. You know, it has been really so huge on our population. I'll give an example. When we had the Cyclone Fred in 2023, on the 11th March, I met a family of 7. They had come from work. The man was working, the wife also working. They come home, low-income family, but at least they ate that night. They went to bed. The cyclone hit around 11, 12, midnight. In the morning, the woman was alone. The husband had gone. All the children were gone. They could not even retrieve the bodies. So there she was, asking herself what happened. So you can imagine the trauma of it all. So this is why really when I hear about what is it that we can do collectively to address issues of mental health, it gives me hope, because the need is there. Our people are suffering and they're looking for help, and we're the ones who needs to provide that help. Thank you.
Thank you for sharing that, Ms. Chiponda. Mark, how about yourself?
Thank you, Ananda. The way I got in contact with this field is, as many people perhaps in this room have a family member. My mother had bipolar disorder, so I know this field from personal experience from as long as I remember. I think fast forward 18, 20 years to study days. Why did I choose a career in this area? I'm interested in the reduction in suffering, as I think is everybody here. It doesn't mean one does it through mental health field. I can do it through any field. But I'm interested in the reduction of suffering, and this is one way of working in this area, one way of reducing suffering. Through my years in fast forward another time till I joined WHO, working on this area, I had enormous support always from my management to work in this area. Why? Because when working in emergencies, we were able to initiate changes, long-term changes in mental health and mental health systems in many of the affected countries, and that's what, at that time, they were very interested in. So I'm delighted with this panel, which is probably the first panel that really connects the emergency response to the long-term mental health system changes that need to happen. Thank you.
Thank you. Valentina.
Thank you, Ananda. Hello, everyone. My name is Valentina Marpis. I'm a Ukrainian doctor, psychiatrist, and psychotherapist. I graduated from medical university with honors and could have chosen any direction to work in, but mental health seems the most exciting for me. An area where still much is unknown, an opportunity to accompany people throughout their lives and be a guardian of their souls. I have around 20 years experience both in practice and in research. I have experience working with refugees, and I have my own personal experience in this matter. Currently at Charité, I'm co-coordinating the Solomia project, which is sponsored by BMZ and the GIZ. Our goal is strengthening a long-term support of medical and psychosocial infrastructure by a network of hospital partnerships.
Thanks, Valentina. Zainab.
Thank you, Ananda. It's always so beautiful and heartbreaking to hear how close we all are to the issue. And I'm no different. I think responding to this question is really personal for me. I struggled with my own mental health growing up. So this field has always felt like a calling for me. I struggled with depression and suicidal ideation. But my journey in this field began in 2006 during the war in Lebanon. My family and I had to evacuate to safety. And when the ceasefire finally came and we returned home, I was at this strange crossroad. I had just finished university and was really trying to figure out what to do and really asking myself, how can I help? And so I volunteered with this organization called International Medical Corps. It's a non-governmental, nonprofit health organization. And at first I was, just helping with translation and interpreting, in the field. But I started to accompany these mental health experts, and I didn't have the technical background at the time, but I had this front row seats to the stories and to the pain and to the fear in children and families and young people and what they were experiencing. And then, I was mentored by people like Dr. Lynn Jones and Dr. Inka Weisbecker, people who supported me as a very young person who was interested in this space, and they lifted me up, creating opportunities for me to take more responsibility and to get into this field, to study mental health. I remember this one instant, there was this big conference that was happening, and I think you were at it, at the Harvard Humanitarian Initiative. And Dr. Lynn Jones said, if Zainab's not going, I'm not going. And it was, for people who know Dr. Lynn probably can really think about the tone in which that was said. But fast forward 18 years, I am a clinical psychologist now, working with UNICEF and leading on the mental health agenda at this organization. I'm always humbled to feel that I can and am playing that role. But I do think one of the biggest lessons in this career path and journey has been the importance of mentorship and really investing in the next generation of professionals and leaders in this space. So I try to give back by supporting young professionals as well, the way that people invested in me. Yeah.
Thank you for sharing that, Zainab. Ahmed.
Thank you, Ananda. For me, it starts in 2011. In 2011, I took it to the streets back in Syria to demand justice and freedom for the Syrian people. Few weeks later, I was shot by a sniper in the face. After 5 surgeries and 5 months of rehab, I got up, I took it back to the street, and I continue fighting repression with even more determination. A year later, in 2012, I was kidnapped by the Syrian regime, disappeared, tortured for 3 years, and when I was released, I got up again, I took it back to the streets, and I continue fighting with even more and more determination. In 2018, I was in Paris working on a human rights campaign. I was sitting on my chair when I received a call that my best friend, who disappeared years ago, and I was waiting for him every night and every day, waiting for his release, he was killed under torture 5 years ago. I got up, I took it, but not this time. I fell down. For weeks, I was staring at my screen, at my laptop, trying to do anything to seek justice for him. And I couldn't even do the simplest task. And I thought, maybe George Orwell in 1984 was right. Repression can break our spirit. Despite my resistance to seek therapy, a group of friends, survivors of torture, pressured me to seek therapy. I did. Few weeks later, I got up, I took it to the street, and I'm still standing. I think if all the change agents in the world were as stupid and stubborn as I was, change will never happen. Since then, I took it to be my mission to fight the stigma and mainstream MHPSS during, and after conflict. And to prove that George Orwell was wrong. My name is Ahmed Helmi. I am a co-founder of the AFI initiative to support survivors of torture, and I'm a co-founder of INNOVAS, the international network of victims and survivors. Thank you.
Thank you, Ahmed. Thank you, everyone, for sharing very powerful and very personal journeys that have brought you to this stage. If I might just add my own introduction to yours, I'm based in Sri Lanka. I have a background in medical anthropology and so on, but my start came in 1996 as a recent graduate in psychology, no skills, no experience, trying very hard not to work on human suffering because, like many of you, I had a family member who'd lived with a serious mental health condition for many years, and I knew the pain, and I thought, this is not something one wants to do daily with many, many people. However, as an intern at an organization that worked with survivors of torture, actually, I was the lowest of the low. I used to, walk people home after clinics, do things like that, and then found myself in a position where I was hearing stories about the types of experiences people had, and also recognizing, along with the pain, the dignity, the strength, and the resolve that people had to find justice, to live their lives, to care for their children. And at the same time, I recognized the fact that many of the things that we were trying to do for them were not sufficient. We were failing them in many ways. We could do better. And so my work, I since then, sort of 20 years on, is very much in that same vein. The field has grown tremendously. We do so many more things much better now, but I think that we still have a way to go. We still confront a world in which the scale of the suffering, the nature of the suffering is ongoing, and where we struggle to respond. So that, to me, is a good reason why we have this panel today, and I would like to start, I think, build on that by turning to Mark, actually, to perhaps invite you to give us a little bit of a picture of what the global situation is like in terms of the needs related to humanitarian emergencies. What's the nature and extent of the need for psychosocial and mental health support?
Thank you, Ananda. This is actually it's a question with many layers of depth in it. The message that we always like to give first is most people who go through a humanitarian crisis are going to be okay. So most people will not develop a mental health condition, and for many people over time, their distress eases. But it's more complicated than that. In our estimates, and that's all, the rates of WHO formal estimates, the rates of mental health conditions are double among populations that have been exposed to conflict in the previous 10 years. So that's an enormous burden. It goes up from 13% to 22%. But let's unpack that further. That is just an estimate across the world, different places, probably different rates, but all of them very high, such a high number. Which mental health system is ready to take care of 22% of the people? But let's unpack that further. Is it just mental health conditions that we are concerned with in this area? No. We're concerned if you think of suffering, we're suffering of the mental suffering and social suffering. It's mental health, psychosocial support. So on the social side, there is many losses. Loss of community, loss of connections, loss of opportunity, loss of identity when people are displaced. Can be violence in the community, huge social impacts. And on the psychological side, not everything on the psychological side is a mental disorder. What about normal anger after experiencing indignity? What about normal bereavement after mass loss? What about fear for the future, because opportunities are no longer there that used to be there. So all those aspects we don't know how to quantify them. We don't have an answer yet. I say yet, it sounds like we're having it tomorrow. We don't have an answer. But we do have some estimates on the range of mental health conditions, and they do double, and there is an enormous need to prioritize areas affected by conflict, to set up proper mental health systems for the long run, because this is very important. These problems don't go away. It's for 10 years that the average rate is up to 22%. That means that there's a need for investment in mental health systems for the long run. And what we see in some crises, that there is an investment for the long run. But in many crises, we do not see that. And that is a concern.
Thank you for that, Mark. So what I'd like to do is now shift the panel on to talking about, what it means practically to respond to needs in these sorts of contexts. Right? And perhaps, Minister Chiponda, I'd like to go to you first, maybe asking you to draw a little bit on your experience of responding to the flooding that you alluded to last year in Malawi as a result of the cyclonic weather. Can you describe to us what was needed in that initial phase of the response to that very acute, sudden onset emergency in order to address psychosocial and mental health needs?
Thank you so much. Just to build on what Mark has said, and he has said a lot, and all what he has said really applies. But what happens when you have a crisis, a cyclone or a flooding, as a society? First, we said, no, we need to provide shelter, we need to provide food, we need to maybe provide medicine. But the thing is, for that person who has been affected, before they even start feeling hungry, it is up here. But the response, initial response, most of the times does not have the component of mental health. And that is a fact. Even in our books, in whatever, it's not part of it. So you will find, okay, let's talk to World Food Program. They'll bring trucks of maize, whatever, rice. Let's talk to Red Cross. They'll bring us tents. But there's no component of mental health. But this is the first thing which is affected in the person's life. Because they're frustrated, they're angry, they don't even know what to do. So I guess for us, we are now, when all is okay, when the waters are calm, we need to integrate mental health response as the initial response in terms of crisis. It has to be part of it. We need to make sure that we have psychosocial analysts, we have counselors to be there, to counsel these people. Because the trauma, the more it takes time, weeks, months, it is doing more damage. It is doing more damage. Unfortunately, some of the damage, you cannot see it straight away, but it affects that person for a longer period of time, even when they have gone back to their homes, but the damage has already been done. So I think for us as countries, or even our partners, we have to make sure that when we are drafting, what should be our initial response if we have a crisis, whether it's a cyclone, whether flooding, make sure that, we have tools to address mental health issues of the persons who have been affected.
Thank you for that response, because it really highlights the importance of being prepared, because we know that the strength of our response is very often, contingent on the level to which we have the resources and the plans and the readiness to be able to provide support in the event of a crisis. Right? I'm wondering whether I could turn to Zainab to ask you a little bit about whether you could share some of the key actions that you think would help us to ensure that community service providers and governments are ready to respond to an emergency, and especially with regards to the quite diverse and complex mental health needs of children, adolescents, and also caregivers.
I think when it comes to children, many of you know that children are really facing unparalleled levels of vulnerability. We have over 200 million children who are living in areas affected by armed conflict. We have 43 million children who have been forcibly displaced. We have 224 million school-aged children who don't have access to learning in schools and other education systems. It's heartbreaking. It's a heartbreaking world for children around the world. And we know that these children are at heightened risk of mental health issues and require that early intervention in order to really prevent development of severe mental health issues, both short-term and long-term. So what does preparedness mean? Preparedness is key, of course, when it comes to addressing these growing challenges. We know that time and time again, governments and mental health community have often been ill-prepared to respond to the mental health needs of the most vulnerable, especially children, and especially when crisis occurs. And it's no longer about being reactive. We need to be proactive and ensure that there are the right systems, health systems, but also health systems working in collaboration with education, with social services, with juvenile justice, all these systems of care that are critical for children to be able to receive the support that they need. And preparedness also means integrating MHPSS into broader emergency response frameworks with resources and personnel and systems that are ready for immediate activation in a crisis. The IASC, or the Interagency Standing Committee MHPSS Minimum Services Package for MHPSS, it's a package that UNICEF and WHO developed with our partners and was later endorsed by the IASC. It was also central to the World Health Assembly resolution on MHPSS and emergency. And this provides a costed framework of predictable activities to support multi-sectoral MHPSS response in both acute and protracted emergencies. What this means is that we have the frameworks. We know what needs to be integrated into national preparedness and response plans, securing buy-in from governments and partners and really making MHPSS as making sure that it's resourced and making sure that it's prioritized. One thing I do also want to mention that is really critical in our preparedness is how are we also responding to this critical gap that is the workforce. You know, we, in all our communities, even within the most privileged communities, we have issues in accessing mental health services, and this is incredibly, incredibly heightened when we think about the workforce that is prepared to support children and young people with their mental health issues. And how do we build a workforce around children, within the home, within the schools? You know, we have a real problem here. So how can we really think about no longer, you know, making it acceptable to bring in and parachuting these experts in crises and not really, which is of course counterproductive and it's not sustainable. How do we ensure that we are actually building from within the community, that the community itself is activated, that there is a workforce there that can be pulled in to respond to these immediate needs during a crisis? So of course, this can only be done through a system strengthening approach, working with governments and service providers to really activate MHPSS services across multiple points of care, in schools and primary health care, in child protection and social services and community programs. And as part of preparedness, we really also need to address social determinants of health and the deep-rooted stigma and discrimination, because it's not only about the availability of the services, it's about the access to those quality services. So really making sure that what we're doing is inclusive and what we're doing is providing better access to services without the stigma associated to mental health and mental illness.
Thank you, Zainab. When you were speaking, Zainab, it made me think about the fact that sometimes capacity is also built during crisis, which sometimes helps us with the next one. And that's certainly my experience in Sri Lanka. But I'd like to turn to you, Valentina, and ask you about how the experience of MHPSS in Ukraine associated with conflict and hostilities prior to 2022 has supported and informed the response to the ongoing war. Could you just tell us a little bit about how that has, those linkages have, how that has perhaps informed it, but also how the MHPSS response has evolved over time for the affected population?
Thank you, Anand. With the onset of active military conflict, many challenges arose for Ukrainian healthcare system. Due to destruction of infrastructures, the displacement of large number of peoples, and overloads the doctors with patients, it was decided to support and strengthen existing system. We sent medications and goods to the large psychiatric hospital in Ukraine in all regions. This has enabled more than 77,000 of patients received medication and treatment with medication from Charité. At the same time, we provided training psychological first aid for non-medical staff. We monitored what activities were carried out by the WHO and international organizations in order not to duplicate activities. The next steps are development and adaptation, the training to prevent burnout for healthcare workers, as well as strengthening maternal mental health in postpartum period. The nature of MHPSS interventions evolved from the short-time crisis management to evolved long-term strategy of supporting. Currently, over 60 institutions involved in our projects, including also clinics, medical universities, and NGOs, and also are part of German partners, network with German partners involved in our project. This made it possible to expand various of implementation of our trainings to Ukrainian professionals. Therapists have possibility to take part in narrative exposure therapy, intrapersonal therapy, and others. The next long-term goals was strengthening our digital infrastructure. This make it possible to support telemedicine, which can reach remote or hard-to-reach person. And also, this is about chatbot friend for people with acute stress, providing online consultations for displacement persons. Solomia app for people who suffered from chronic stress or have sleep disturbance. And of course, our e-learning platform, Medically, which can give reach the gap and possibility to our professionals receive up-to-date knowledge. With presenting the material, an avatar with artificial intelligence is used, which made it possible to immediately translate each lectures to any language. However, we recognize the need to develop sustainable programs to support community with resilience and cohesion. That's why group therapy approaches have been developed. This holistic approach aims to not only treat symptoms, but also address the underlying factors that can support community and be ensured that promoting for our people resilience and cohesion.
Thank you, Valentina, for that a broad description of the wide range of actions that you and others have been taking in a context that sort of illustrates to us the repertoire of actions that we can take, but also the range of needs that they need to respond to. I'd like to stay on this sort of theme of the longer term. Because Mark, you and WHO have been very active in championing the mantra of build back better, right? Using and trying to look at crisis response as an opportunity not only to respond to acute needs of individuals and communities, but also to do more systemic work to essentially meet what you alluded to, the medium and long-term needs of the crisis, but also of life beyond crisis. Could you tell us a little bit about what approaches would help us to do this, particularly in relation to health systems?
Yes, of course, I'm excited to talk about that. I think the term building back better came from Bill Clinton during the tsunami response. And it was quite popular and quite politically neutral for many years until the Biden administration used it in its slogan for its campaign 2020. But so we have, until 2020, if you would Google Building Back Better, you would get our WHO publication on how to strengthen the mental health system. No longer, of course, if you Google that now. But let me just summarize what our lessons learned on Building Back Better, which for many years has been our three-word way of summarizing what we think should be happening to mental health systems after emergencies, which is starting with the concept of early recovery, which is no longer used so much anymore, but basically means that when the crisis happens, that from day one, you start planning for long-term response, including making sure there's funding available. So the funding in humanitarian crisis is often decided early on. If one doesn't program for a long-term response or plan towards it, it's not suddenly available 1 year after the early crisis. And you can, for example, fund for demonstration projects on showing how services could be set up in regions. And those services need to address the broad mental health needs, not just PTSD, but also the needs of the people with pre-existing severe mental illness who are at extreme increased vulnerability also in emergencies. One needs to respect the central role of government, obviously, if one wants to set up a long-term mental health system. One needs to work with national actors, one needs to coordinate, one needs to advocate to maintain the momentum, because during crisis, everybody's interested in mental health. But after the crisis is over, not for sure. So better set up your advocacy for long-term momentum. Thank you.
Thanks, Mark. Yeah, this is one of Mark's pet issues, which we've all championed as well. But unfortunately, in many contexts in the world, there is no after. We are seeing lots and lots of situations where there's chronic and ongoing crisis or polycrisis, and I'd like to look at some of the complexities of that, and maybe turn to you, Ahmed, to bring you in to speak about some of the challenges that exist to support survivors in situations of ongoing conflict and political repression. Can you share some of the difficulties in providing support, and also some of the kinds of support that can make a difference to the lives of survivors of human rights violations?
I would say that the challenges and the difficulties are on many different levels. The first level, to be honest, is with the survivors, with the community themselves, because during the conflict, you would think that I need the conflict to be over. I need justice. I need the killing to stop. I need the fight to stop. Mental health is something secondary. It's not something I'm going to deal with right now. And you have, on another hand, the feeling of stubbornness and that we are strong as survivors, as a community. We're resilient. We don't need that support for the weak. And that was also a stigma. I see it dissolving day by day, but it still exists. Also, the matter of resources, Zainab just mentioned, in the most developed countries, you don't have that much of resources, mainly of human resources. I'm not talking about fund or money, which is also another challenge, but the human resources is a huge gap. And the other challenge on the discipline itself is, up until today, it has been seen as an isolated discipline. It has not been integrated in many other interventions during the conflict. It should be integrated in every humanitarian and development intervention throughout the UN, throughout the decision makers and the donors, also by the local actors. If I want to say, like, what is working during conflict, I want to ask every one of you, when was the last time, or like, have you seen one of your best friends in the past 2 weeks? Excellent. Have you danced in the past 2 weeks? Great, thank you. It is building on the local capacities and the local culture. In Guatemala, for example, one of their ways to deal with the grief is to dance, is to do a ritual. And if you invest and empower those kind of heritage and cultural practices, you are actually dealing with the problem, but in more an innovative way. So building on those local capacities, local cultures. In Syria, we did support with a very small grant. We did support 5 years ago a group of students to study psychosocial, like to study that discipline in many different universities. After all, they didn't get a degree, so they can't practice, but they can practice in Syria. And now they have been doing amazing work in Syria. So we kind of learn how to deal with that resources issue. Also in Syria, and now we are doing it in Colombia, in DRC, there was a concept called the ambiguous loss, developed by Pauline Post in the US. Now we are bringing that concept and we are localizing the concept on how for like the families to deal with the loss of their beloved ones and how they can mobilize and build their own resilience. And this has been working, because when we think about MHPSS, the first image that jumped into our mind, like I ask you, what do you think? You might think that a white chair, someone lying down on the white chair, and there is an old guy with the white beard smoking pipe, asking, how did you feel about it, right? But this it's way beyond, and it's evolving, and it's becoming more multidisciplinary approach. Recently, we did something, I'm just mentioning examples on how you can build on existing resources, existing capacities. We asked mothers of the disappeared in many different countries to cook their sons or daughters who are disappeared favorite meal and share it with others. That was an extensive way for them to share their feelings and to feel that they are not alone. And it has been working. So it is difficult, but there is always innovative ways to get around it.
Thank you, Ahmed, for sharing that. I think, the things you identify in terms of, who's really the front line for any of us if we're in crisis, it's the people around us, the people who are close to the ones who remain, and the kinds of resources that we have within kind of, the meaningful cultural practices or care practices or social practices that allow us to make meaning and to cope with losses that are otherwise incommensurable. Right? So thank you for sharing that. So we're sort of halfway through the panel now, and I'd like to spend the remainder of our time really focusing on the panel's ideas about what remains to be done to better address the needs of affected people and how we might all work together to achieve that. So one of the things that has already come up is that we sometimes face significant challenges to ensure, given the scale of needs, that individuals, communities, and systems have the kind of support that they require. And I'd like to turn to you, Minister Chiponda. From your perspective as Minister of Health in Malawi, what do you identify as the key priorities that need to be addressed to bridge this gap?
Thank you. I think for us, the first thing which I feel we have to do is to create deliberate awareness of mental health issues in the community so that there's also community acceptance. And the other issue which I feel that we need to address, it's not all the time that the mental health patient has done something wrong. Because most of the times when somebody has a breakdown, we have to ask, what did they do? What did she do? Is she abusing drugs? No, maybe alcohol abuse, something. No, it's a sickness. And that has to be accepted. They have done nothing wrong. And the other one, which I feel, is that we need to know that mental health is part of the SDG 3. If we're saying we have to attain SDG 3, good health and sound well-being, we also have to include mental health. So that puts it in perspective that in the next 5 years, we need to see a change. So for us as a country, Malawi, what we're trying to do now is to incorporate mental health in our primary health or community health roadmap. To make sure that people have access. In our case, we should not even talk about the crisis. Even without the crisis, people, they need to know that they have somewhere to go when they have mental health issues or challenges. They need to know that at least there's a community health care who is going to assist me if I have questions, who is going to take care of me. And so the gap is there for now. What we're asking for is that we need also to ask our partners, because we have so many partners in the health sector, but very few who are going to support you on issues of mental health. If all of us, we had the zeal and the commitment like we have done in combating HIV, AIDS, tuberculosis, malaria, all these other diseases, I'm telling you, I would have been somewhere on the issues of mental health care. But we find very, very few who are interested. Once you start talking about mental health, very few, very, very few. So now we have said, okay, as a country, Malawi, we have our one plan, and that one plan includes mental health. If you want to support Malawi on any other health issues, you have to support our one plan. And our plan contains mental health. So now we're running away from vertical programs. No, we are looking at the person. This person is the same person who is going to have HIV. It's the same person who's going to have maybe NCDs. This is the same person who will have mental health issues. It's just a person. So we are looking at a person-centered plan and not only a disease-centered plan. The reason is that whatever resources we put together as a country and our partners, will also be able to take care of mental health issues. Thank you.
Thank you very much for that. I'd like to pose the same kind of question to you, Zainab, as in your role as global lead at UNICEF. What do you identify as some of the key priorities to be addressed in relation to this, the gap in terms of needs, particularly maybe in terms of building systems that would ensure sort of sustainable mental health and psychosocial services across sectors?
Thank you so much, Ananda. So for us at UNICEF, the key priority is ensuring that everything we do in emergencies is centered around the needs of the child, and we need to really be able to create the support systems around the child that meet these needs. There are a few things that we can do that I really, truly believe can make a huge difference. First is community-based interventions, which are really vital to reaching children and families directly in their environments. I think, Ahmed, you touched on this, resilience. I really want to reiterate this. I think the biggest misconception, the biggest lie that we have been told, especially when it comes to children, is that children are inherently resilient, that they're going to be, in emergencies, are going to bounce back, that even if they have witnessed or experienced deeply distressing issues or traumatic events, that they will get better. This is a huge misconception because resilience is nurtured. It is not inherently there. For us, when we think about children, we think about them kind of like in this, with circles of support surrounding the child. We need to really be thinking about the mechanisms in a child's life, whether at home, in schools, or in the broader community, that we can build through this socio-ecological lens that can really support children. If in an emergency, a parent is worried about getting food on the table, making sure that there's shelter, making sure that the family is safe, and their mental health is often deeply impacted, and they're unable to provide, not because they don't want to, but because their attention is taken away from that ability to connect with their child, to see if their child is doing well. Similarly, teachers in emergencies, they are often taken away from their regular job. They're trying to set up schools or different alternative educational channels outside in camps sometimes, and their own mental health is also impacted. How can we support them to better support children in that way? And so on and so forth. These examples are really thinking about the broader community that surrounds a child and the systems that exist around the child that is able to care for them. The second is evidence-based interventions. A few years ago, if you were to ask me, do we have evidence-based interventions for children and young people? I would have said, well, we know a little bit. We have some things that are available to us, things that we often have to adapt in the field and pull from adult or pull from content that has been developed in the Western world and try to apply it elsewhere. That has not served us. Now I can really wonderfully and proudly say we do have a suite of evidence-based interventions for children and young people. We have a Caring for Caregivers package for children under 5, where we train frontline workers to support parents and caregivers' mental health. We have Helping Adolescents Thrive, which is this prevention package that we developed with WHO to support adolescents. We even have psychological interventions for early adolescents. WHO developed EASE, and we now as UNICEF are working to help roll that out, and so on and so forth. There are gaps, certainly, but we know enough and we have enough to be able to scale these things across the different systems. The last thing I will say is innovation, which for us as UNICEF and within all of our worlds really is a key priority. Digital technology touches nearly every aspect of young people's lives, even during emergencies when we have the traditional social structures that are disrupted. And at UNICEF, we are really working with partners to see how we can use digital technologies to support children, including in emergencies. We have this wonderful partnership with Spotify that has helped us co-create content with young people in Ukraine, actually, to support young people who are impacted by the war. And now we are scaling it up and adapting that content through our youth networks in Latin America and in the East and South Africa region. So there are things that can be done, but you might be asking, can harm be done online? Yes, we as UNICEF acknowledge that there are huge risks in our engagement in that digital space. So we are developing content to safeguard and protect people online, and really kind of think about the digital solutions going hand in hand with non-digital solutions and structures. It cannot be implemented in silo. And so when we talk about systems of care, we're talking about multi-sectoral systems of care, but when we're talking about solutions, we're also talking about multifaceted solutions that need to go in hand together. Sorry, I did say one last thing, but really one more last thing, which is, because I really think it's important, is emergency frontline workers. We talked a lot about what we do for young people, for children, for impacted communities, for survivors. What about those people who are providing that support? It's just so utterly important and critical that we prioritize their mental health, especially now this week is World Mental Health Day, and the focus is actually on workplace mental health. So for those who are in contact with children, with young people, with impacted communities, what are we offering them? I'd love for you to research Talk to Me or Tamminni Annak, which is this package that was developed after the Beirut blast by UNICEF to support frontline workers, certainly not at the exclusion of our efforts to create the policies to support frontline workers within that workforce space, but certainly something that is critical and that is can be used and is a wonderful resource. Thank you. Yeah.
Thanks, Zainab. I'd like to go back to one of the things you said about the need for multi-sectoral responses, and maybe go over to you, Mark, because in 2007 you were part of the group that put forward the ISC MHPSS guidelines that really enshrined the idea that MHPSS was a multi-sectoral endeavor. Could you talk to us a little bit about what sort of cooperation, coordination is required to actually meet needs across different kinds of institutional actors within humanitarian work, but also within public sectors in affected contexts?
Sure, this is an issue that keeps coming back and coming back. If you think of sectors like health, nutrition, education, all that, this area, for those of you who are new in this meeting on this topic, this area is right cross-cutting, right through it, with most of the activities usually happening within child protection and health and some in education. And for years in the field, agencies are struggling how to coordinate that. How do you coordinate across sectors in the middle of an emergency? So we found over time that the model that seemed to be most likely to work is a cross-cutting technical working group that cuts through with leadership, co-joint leadership between a health agency and a non-health agency. And when it's situated differently, you will find that all the different psychosocial mental health projects in different sectors just report to the line ministry or the line sector, and there is no coordination across. So that's really the structure. There is currently in humanitarian settings, there used to be about 30 of these technical working groups around the world. Now there's 59. It's a great increase, and so it's super important. And I want to say, even for high-income countries, these are interesting models because there's a similar issue of coordinating mental health and psychosocial issues across ministries. And in South Korea, there is for suicide prevention, it's under the prime minister because it's really enshrined as cross-cutting. So there's also something to learn. It's called reverse innovation, to learn how things are done elsewhere that can be used by donor countries.
Thanks, Mark. I'm going to go to Valentina for a question about a different type of cooperation, which I think you're very well placed to speak to as a Ukrainian mental health professional who's living in Germany and supporting work in Ukraine. And that's really about the role that professionals who are displaced or living outside of their countries of origin can play in supporting vulnerable people and survivors of conflict, either who are outside of those conflicts, displaced outside, or who are still living in active conflict contexts.
Thank you, Ananda. I think it's a very important question, and I really don't know how it's better to answer we or they. As you know, currently a lot of crises around the world, it's around 60, I thought. And because of this, we have a lot of displacement persons and the same situation with professionals. The professionals who are displaced or living outside their countries hold a unique and impactful role in supporting survivors and people who are vulnerable. They can advocate for resources. They can underline very important issues which may be overlooked. Their first-hand experience and cultural understanding enable them to offer specific support for their community. One of the important roles of these specialists is support mental health or health system through remote digital infrastructure, for example, providing telehealth or online counseling session, which can bridge the gap to support people when in-person support is not feasible. This professional often aids as vital links between international aid organizations and local populations. They can take part in advocating resources and provide new politics. They can involve in new possibility to create new structure in countries where they are currently present. Sorry, I really worry about it because I'm thinking about my way, about my experience, how I started here in Germany, how we collect organization between different levels, between Ministry of Germany and Ukraine, between head of hospitals, between rectors of university, between professionals, and it took a lot of our strengths and it provide really great support. I really appreciate Germany Ministry for support of our collaboration and Ukraine system also. We can additionally support, we can support system, we can share our experience, we can create more sustainable platforms, we understand culturally problems, and we can understand the situation, we can predict situation. I can say that we understand what kind of situation can be, for example, in other places and prepare other specialists. We can share best practices, we can develop educational material, and we can support systems. Moreover, by engaging in advocacy and policy, we can bring the attention from international organization and bring attention from global population. And our unique position enables us to navigate very difficult problems in countries, and we can ensure and promote possibility to create system which support everyone affected for well-being and resilience. Thank you.
Thank you, Valentina. I think you illustrated just the importance of, one, that having people who have deep knowledge but also deep commitment to the process, but I think also highlighted the fact that, as much as we have general lessons for what should be done, the process of creating the response in a given setting and mobilizing actors and actions is often one that involves creativity, negotiation, and a lot of hard work and commitment. And I think that's something perhaps it's good for us to all remember. It's never one size fits all. You've got to contextualize. I'd like to end this round of the panel before we open up to the audience for some questions with coming back to you, Ahmed. I think I'm giving you the difficult questions because, one of the issues we have is that in chronic and protracted crises, there's often this challenge to sustain services and supports, and we often know that, and Mark alluded to this, that resources are not always equitably distributed. Sometimes they rise and they fall with changing contexts and also shifting global attention. So what approaches would you see as important for continuing work that is needed to support populations that are living through crises that perhaps don't seem to have an end in sight?
So you're giving me the hardest question, even though I'm the least experienced of the panel. Something is personal here. That's so tricky. In traditional justice processes, doesn't work when you have a conflict. In a conflict, you tend to do a different approach called dealing with the past or transitional justice. And that also should apply on MHPSS. In conflict, you cannot approach it in the ordinary and regular way. You have to see it as dealing with what happened, what is happening, but also preparing for the future, right? Because if, as Mark said, it's not just a disorder or like a sickness. It could be social, it could be communal, it could be on the level of the whole community, because a tired individual makes a tired community, and a tired community cannot build a future for the country. So it needs to be dealt with in more mid-term response and also in a long-term response, in a long-term strategic thinking, building on the national capacity, the local capacities, while also preparing for the future. And instead of outsourcing and bringing expertise from different countries or from different contexts, you can do that on a short term, but you have also to prepare and to build for the longer term, because the money will disappear, the fund will disappear, the political interest will disappear. We are seeing that now in Ukraine. Like Ukraine, after 2 years, now the international political support and the international political will is degrading, and this is very sad, but it is the truth. So we need to think about how to build how to systemize MHPSS in every discipline for the future. And we need to sense the urgency of the matter. As the ambassador said, it's not something easy like we can do it today and forget about it tomorrow. It is urgent. How many of you have inherited some of their parents' trauma? And since there are some parents in the audience, how many of you are giving your traumas to your children? If we don't deal with that, imagine traumas after traumas, the future generation will be in a bad place. Finally, yeah, I would say the social and the individual and the cost on the social level and on individual level becomes higher and higher with time. So if we deal with it now, if we build systems, then we will know that in the future we will have that kind of sustainability. And again, back to my previous point, build the practices, build on the practices of the culture and of the local communities.
Thank you for that response, Ahmed. I'm just looking at the time, and I know that we don't have a lot of time for question and answer, and I want to give the panel a final final word before we close. But I think we have time for a couple of questions from the audience. So the gentleman with the yellow tag was very, very quick, and perhaps the gentleman with the checked shirt over there, and we'll take those two and see how we get on. Yeah, in no particular order, yes. Okay. If you don't mind.
Thank you very much, and thank you for putting together a very enlightened panel. My name is Lukoya Tuli. I'm a psychiatrist from Kenya, and I've really enjoyed this panel. Just to summarize, I think you've been preaching to the choir, so that might explain why the moderator thinks we shouldn't have any questions. But I do have a question for Minister Chiponda. Everybody else has a number of lamentations about what needs to be done, I would have loved to hear from you as a minister who sits with the president and sits with other ministers of health. What are you doing to improve the situation in Malawi? Is there practical action? Is there funding that you're actually setting aside to start incorporating MHPSS in the health system and in every other interventions in government? I would really have loved to hear that. I know Malawi has very few mental health workers. You have a plan to deal with this. This is something I would love to hear. Thank you.
Thank you. Could I just have the other question come as well before you respond, Minister? Just pass it on over. Thanks.
My name is Klaus Fleck. I'm a medical journalist for Medscape Germany. And as many people, there are many people who have fled countries or regions in crisis. My question relates to the mental health and the situation of these people, of refugees who are living in host countries like Germany, for example. So my question, what is necessary as a first step to identify refugees who are in critical mental health conditions? Second, what should adequate mental health and psychosocial support in host countries look like? And third, what can be arguments to convince policymakers in these host countries regarding the financing of this support?
Thank you for your 3 questions. I will just hold now and perhaps ask Minister Chiponda to go first, and then any one of the other panel members to respond to the latter questions.
Okay, no, thank you so much for that question. What I can say just in a nutshell is that as Malawi, we recognize the challenges which are there in terms of infrastructure, in terms of human resource as well, the gaps which are there, and of course, operating under very tight fiscal space. So what we have done is what I was talking about, that now we have developed our health sector strategic plan 3. We have one plan as a country, and we have invited all our partners that they have to go by our plan. Because, like I said, what was happening is that we had several vertical plans, programs, some of them doing very, very successfully. But others, especially mental health, were not doing very well. We have got huge gaps. So we are saying, no, if you're supporting us as Malawi to say, no, we'll give you funding to recruit for malaria, we will not say we're not recruiting for malaria. We are recruiting healthcare workers as our needs. So that is what we have done, and it's proving to be really like a game changer, because now we have the opportunity to recruit different cadres, including those working in the mental health care and management, as well as the infrastructure. We have also integrated mental health in our community health strategy or framework to make sure that even at a community level, people, they have to be assisted. But the thing is, it's not an event, it is a process, and it's going to take time to build capacity of our healthcare workers, but also looking at infrastructure as well, because even facilities, most of our district hospitals, they do not accommodate mental health care and management. You find that is a huge problem, but we have recognized it and we are working on it. So that is what we have done. The one plan, one budget, and one monitoring and evaluation that takes care of all the issues under the health sector. Thank you.
Thank you. Mark, you want to take this one? You signaled that you did.
I would like to, I can answer all of them, but I would prefer to definitely answer on the reasons for investing in it, maybe the rationale, which I think we articulated quite recently in the World Mental Health Report, which has a whole chapter on the 3 reasons for investing in mental health. So reason 1 is for public health. Health is the intrinsic value of investing in mental health. It's part of health, and for the reduction of suffering, and also the association between mental health and physical health issues. If you address mental health, it's part of the pathway of also addressing physical health, if you think of the adherence issues to chronic physical health care. The second reason, human rights. So two issues within human rights. One is that health is a human right. Second is that the healthcare system in mental health often violates human rights. Third, socioeconomic. So if you're a leftist government, you may go for the human rights argument. If you're a right-wing government, you may go for the socioeconomic argument. But there's a return of investment of mental health. 1 in 5, $1 in, $5 back for society. And it's not only financial, it's also, for example, you invest in children's mental health, educational outcomes, it will be better. So those are the 3 arguments for investing in mental health, and they apply just as much to refugees, or even more, given their increased needs.
In the interest of time, perhaps rather than give an outline of what programs might help, are there any resources that you might suggest to the gentleman in terms of guidance around support for countries hosting refugee populations?
It's a painful question for Germany. I understand it. You received around 3,000 of doctors and nurses. And I understand the bureaucracy, and I'm studying German because it's very difficult currently speaking English. But you received professionals who can support, who can influence. I understand your question, why I'm here. And I can answer that here, yes, I'm safety. In Ukraine, I can support hundreds of patients. And here, in this situation, I can support thousands. And I think it's very useful for my country. It was my child dream to support my city, my country. It's very painful to receive information about bombing, and very difficult to speak about it because my family partly in Ukraine. But German system, despite the bureaucracy, received a lot of qualified professionals. Currently, our war unfortunately didn't stop. And I cannot stop when it will be finished, but as a professional, I can predict what kind of problems we look at in our future. I'm speaking not only the PTSD, I'm speaking about addictions, I'm speaking about suicidality, I'm speaking about reducing of children in our country. It's not about money, it's not about territorial, it's about life, everyone, and influence. Of course, it influences all around the world. From my point of view, we should be more solidarity, support. I understand that it's very difficult time go ahead, and a lot of countries need support, but currently I'm speaking about our humanity. To be support, to be a human, to understand, sometimes give support, sometimes be able to receive support. And resources, we'll see. It's not an answer for today. Thank you.
I see that the finger's ready. How am I going to choose? We had a pact as a panel that we knew that we would not have the time, but we were going to invite you all to join us for coffee afterwards. So the invitation stands. I'm going to take one last question, but I'm going to do. Okay, it's the lady with the light long sleeve thing over there. Yes. Thank you. Yeah, just shout out.
Okay, it works now. Hi, I'm Ustesa Kolskaita. I'm with International Youth Health Organization and also a member of Lithuanian Medical Students Association. So I'm a medical student myself, and I'm very interested, especially in climate and health. So one of the biggest and ongoing crises right now are the climate crisis. And there is a lot of climate anxiety, especially among young people, because we cannot imagine our future, our healthy future, and our healthy children's future. So my question would be, how do we address that climate change, anxiety, and mental health burden during the climate crisis while the world is struggling to deal with the climate crisis? Thank you.
Thank you. Would anyone like Zainab?
Thank you so much for that question. One thing that I hear time and time again from young people across the globe, youth networks, UNICEF has youth networks across 7 regions of operation. The 3 things time and time again, without fail, that they say these are issues that they care about: mental health, climate, and jobs. Without fail, those are the 3 top things that they tell us they care about. And I was one of the first always, when we had discussions about climate and mental health, climate and anxiety comes up quite a bit, eco-anxiety. It's almost exclusively the thing that shows up in media. And I was always, well, we don't have enough evidence, and there's not enough literature that kind of backs up this phenomenon of eco-anxiety. Then I went and spoke to young people, and young people are worried. The anxiety is so real. I saw it, in engaging with them. They are worried for the future, and they want to do something about it. So I agree with you. It's a critical thing. I do need to say, when we do talk about the intersection of climate and mental health, we need to consider, especially as part of this conversation, when we talk about crisis also includes natural disasters that are induced by climate and ecological crises, right? So that we do need to also think about the mental health challenges that are tied to the climate crisis that is inclusive of climate and anxiety, but not only about climate and anxiety. And I think the way to address it is to do more research. I think we need, and we are working, there's this wonderful group called Connecting Climate Minds. Please look it up. They have a wonderful resource hub that has now kind of mapped out research priorities across different regions, including a focus on eco-anxiety and the types of research that needs to be done in order for us to appropriately address it in the field. So we are working towards it. We are engaging young people through activities. Maybe one thing I also say usually in these types of, when responding to these questions is, we're not doing something new. When a young person who is anxious about climate, we can really support them in the same way we're supporting a young person who's anxious about another uncertainty in their life, because climate and anxiety is really tied to this uncertainty and fear. So there are enough evidence-based interventions that we could also utilize with young people in that way.
Thank you. I am afraid I have to draw a line under our panel, but before we go, I'm going to just ask each panelist very, very quickly to share with us a parting thought about their hope for the future. So the question is, if we were to meet again here in 5 years or maybe 10, you can take your pick, what do you very pragmatically hope that will have changed or advanced in the way in which mental health and psychosocial support is made available to people affected by crisis across the world. And I'll start with Minister Chiponda and move down.
Thank you. Like I said before, that mental health is part of the SDG 3, and all of us were saying we have to attain that by the year 2030. So it is a tall order. It means we have to do something now. But for us, I think the most important thing is we have to clearly, outline what exactly, what kind of support are we talking about. We need statistics. We need figures. In the case of Malawi, we'll say in 5 years' time, we would have recruited a number of healthcare workers who can manage, be involved in mental health management and care. We would have, have a specific number that we have 10 hospitals which, we have provided support for mental health, but also the outcomes in terms of reducing instances of suicide, because it has been on the rise in the last 5 years, which is a clear indication that things are not going well. So those are the outcomes or indicators which we have to work on to make sure that when we come in 5 years' time, we compare the figures of what we have today and those of that time and see if indeed really we have made a positive impact in terms of managing mental health issues. Thank you.
Thank you. Mark.
5 years from now, for the crises that are over then, I hope that every one of these crises will have a Building Back Better response, both for mental health and social care systems. And for the crises that are still ongoing, let's hope none, but reality, that there is building of mental health and social care systems during the crisis because these needs are right there, right now, and we need to be there for the long term.
Valentina.
In 5 or 10 years, I hope that mental health and psychosocial support becomes a standard answer and standard part of all humanitarian responses worldwide. And I think that digital infrastructure will be much stronger, and of course artificial intelligence will be used because we have now so many practitioners. And with education and awareness, I hope that we can reduce stigma about the mental health and encourage more people to seek help and provide such sustainable and culturally fit programs that everyone affected can receive support with necessary psychosocial resources.
Thank you.
I have 3 hopes. The first hope is that mental health is seen as a fundamental right for all children in crises. The second hope is that mental health no longer remains underfunded across every single thing that we do. At the UN General Assembly last week or a couple of weeks ago, mental health was wonderfully, overwhelmingly represented across everything. It was really wonderful to see. I think someone said a few years ago, mental health was visible through its underrepresentation. This Anga, it was visible through its presentation, which is, I think, something that's really great. So I hope the time for convincing is over and the time of doing is now, and that in 10 years it's no longer underfunded. And then my third message of hope is I hope we can connect mental health advocacy with a call for peace. Speaking up for mental health means advocating for a world where children grow up safe and free from conflict and free from the impact also of climate and ecological crisis.
Ahmed.
So, in 10 years, I hope that no one will ask AI when they're feeling down and blue, what I'm gonna do, and then the AI would say, go kill yourself. I truly hope that AI don't take that role. But ideally, I want to see the root causes of that need disappearing. I really want to see the root causes, the oppression, the conflict, the occupation, all ended. But that's not gonna happen in 10 or in 15 years. So I want to see MHPSS being localized and contextualized in each and every culture, religion, and region. And I would hope to see MHPSS being part of each and every early recovery, reconstruction, and peace plan. Thank you.
Thank you, Ahmed. And we have a minute left, and maybe I'll share my hopes as well. I think, whether we're talking about survivors of torture, children in communities affected by climate change, families have disappeared, refugees, I think my hope is that in 10 years we would have really made good on the slogan, nothing about us without us, and that we actually will have methods by which we involve affected people in the design and implementation of services to address the priorities that they have in relation to their mental health and well-being. So it just remains for me to thank all of you for coming here today and for participating in this panel and giving us your time, and of course for you to join me in thanking our wonderful panelists. Thank you. You spoke so well.